I'd like to briefly touch on the classification I use in my head for common orthopedic disorders, and more importantly, how it significantly differs from most of the orthopedic thinking that's out there. So first of all, we have muscles. Muscles can obviously be injured. I argue they're injured much, much less than people think they are, but nonetheless, we have this taxonomy for muscle insults. We have first degree strains, we have second degree, and we have third degree. And the third degree of strain could be a complete rupture, and then those small subsets of people could be the ones that require surgery. Ligaments have a similar classification system in that we talk about first degree sprains and second degree sprains and third degree sprains. And they follow a similar pattern in that these are the ones that might be ruptured and require surgery. But for the most part, the large majority of these patients, strains and sprains can be healed with an environment for healing over time and specific physical therapy or specific modalities that are not invasive. Now, here's the big difference. When it comes to joints, we don't have that three-tiered system in place. We don't have it in the orthopedic mainstream. We do understand that joints can sublux, that is, the joint can move out of its normal mechanical resting position and move back into it. For example, both of my shoulders have subluxed for as long as I can remember. It's only voluntary, not involuntary, but I can easily separate my shoulder and have it come back into place. So subluxing is commonly accepted, and it's not that common in the populace, but it does happen. And then the third degree for for joint problems would be a frank dislocation. And that's similar to the subluxation in that the joint is moving outside of its normal resting position, but a dislocation can be more or is more egregious and often requires the assistance of somebody else and sometimes surgical interventions to relocate that joint to its normal mechanical resting position, its anatomical position, if you will. But we don't have terminology or an understanding of this region when it comes to joints, and that's where I think Robin McKenzie's work is so paramount. He came up with the concept of a joint derangement, and that's when something is mechanically disturbed in the joint and creating problems. And the exact mechanism, the exact anatomy of what's being disturbed in that joint remains to be discovered. But we don't need to know the exact anatomy or specific tissue or structure that's involved when we have a rubric that he developed that allows us to use repeated movement testing to deduce if someone's problem is a joint derangement or one of these others, of course. And then, of course, another huge subset of other orthopedic disorders like frozen shoulders or cartilage damage or any number of things. But when it comes to derangements, I want to highlight what exactly we use as the definition of a joint derangement, which is it's going to have limited and or painful range of motion. So we're going up here to define it. That range of motion limitation is nearly always visible to the naked eye. The exceptions might be in the spine because the spine has several vertebral joints moving at one time when you ask the spine to move. That painful and or limited range of motion is often in more than one plane, but it can be just in one plane. It could have possible plus or minus weakness. And I put weakness in air quotes because if I test the shoulder external rotators or if I test the shoulder abductors and they're weak on my manual muscle test, but then we repeatedly move your neck and those tests become strong or negative within minutes, then I really don't think we should be using the word weakness, but that's the word that we have to use right now. So plus or minus, so possible weakness associated with that joint derangement, could be or could not be nerve tension. So possible nerve tension that's associated with that joint derangement. And then most importantly is that those signs and symptoms, local and or referred pain. Local and or referred symptoms. The joint derangement can create local symptoms at that joint, or it could be referred, or it could be both. So we have these 4 here, but these alone do not identify that we have a joint derangement. These make us think we might, but then we use repeated movement testing. And by using repeated movement testing, we move a joint into a specific direction, or more accurately, we have the patient move their joint into a specific direction. For example, 10 knee extensions, or 10 elbow flexions, or 10 left side bends of the neck. And then we reassess what is going on with the patient's baselines. So if a specific direction positively influences these in a lasting way, then it meets the definition of a joint derangement. So again, this is kind of the taxonomy that I'm using when I think about orthopedic disorders. I think we have been missing this group, this pathology here. I find that 70 to 80% of people with orthopedic disorders have this. What orthopedic clinicians I find are trying to do is fit them in these boxes, even though the presentation doesn't make any sense for a muscle problem or any sense for a ligament problem when you really think about it. They just don't have another way of thinking about it, so they make square pegs fit into round holes. But joint derangements are what I find most patients have. We figured it out by using Rob McKenzie's repeated movement testing. We figure out that the specific direction that fixes the joint derangement by using consecutive and subsequent repeated movement testing with the patient. And it's my, career hope that more and more clinicians will start to learn the repeated movement testing developed by Rob McKenzie, and therefore we can improve our patient outcomes with all sorts of orthopedic problems.